So I've been asked to speak about isometrics in tendon pain, and one of the things that really resonated this morning in Ellen's presentation was the slow thinking and fast thinking. Because if I just present the research on tendinopathy, we can all go to afternoon tea really early because there's not very much. So what I'd like to do is take the research and also help or provide you with some of the things that we use clinically. So this is a combination of clinical experience, and I'm very grateful to Jill and Craig because their intellectual property is well embedded within this, as you'll see. Okay, so by now everyone is passionate about load. We know that we need to load tendons. The clinical challenge is what load? What load do we start with? How do we know which protocol to apply? Because in fact, we've seen that you cannot take the same protocol and automatically apply that recipe to a different tendon or a person of a different age or an athlete that's in season. And so it's very hard clinically to look at the research and know how to manage tendinopathy. We also have challenges around adherence, and we've seen from the research that compares heavy, slow resistance with eccentric exercise that adherence is a really big factor. It doesn't matter how wonderful I think my exercises are if the person isn't going to do them. So we have to really consider adherence. And central to all of this is that people present with pain. So it can be really difficult for someone that has load-related pain to convince them to load and to really get them started. What's our start point for people that present to you with tendon pain? So I'm thrilled to be able to share this story with you because not enough people know the history of isometrics. So Jill and Craig very much use reverse engineering. So it was the concept that we know that our energy storage loads, our fast loads where we ask our tendon to store and release energy like a spring, we know that overload of this type is provocative for tendons. That's what gets people into trouble, okay? That's the load people present with. But as you heard from Jill, complete rest is detrimental. We lose capacity in the tendon, the muscle gets weaker, we lose capacity in our kinetic chain. So we have this sort of merging of ideas where they started clinically applying static load. So it's a load that is not fast because it's static and it's out of compression. So it's avoiding the two loads that are provocative for tendons, but it's still applying some load. And that's really how isometrics started, was a clinical kind of coming together of minds. And this Mario took for us. I had to crop myself out of it, but it's a lovely picture. So it's great to have clinical experience, especially on the back of sound reasoning and first principles, but then the next stage is really investigating this in a systematic way. And so we asked a research question, and I'm a physio, I still see patients. So the research question was, what load could I apply right before an athlete was going to play or train that would reduce their tendon pain? And in order to answer this question, there's a few things that you need to know. You need to know, is there a difference in the type of load? Is it just that I'm warming the tendon up? We know about the phenomenon of warm-up in tendons. Does it matter what I do? Is there something special about isometrics, or is it just because I'm doing something? And critically, for us to be able to implement it in our clinical practice, we need to know the effect on the muscle. Because if I get my athlete to do an exercise that takes away their tendon pain, but they have completely fatigued their muscle and they get another injury or perform badly, I won't be very popular with the coach or the athlete. So it's really important that we understand the effects of this type of load so that we can use it clinically. We also then needed to conduct a substantial amount of pilot testing to get to the stage of doing research. So for 18 months, I pilot tested this study, and I would like to share that pain with you now. So we designed a crossover study where we compared an isometric load with an isotonic load. And we did that so that we could ask the question, is there a difference in the type of load? One was static, one was moving, but they were matched for time under tension, they were matched for rating of perceived exertion, rest periods, all of those things. I was very interested in the brain, so I used the transcranial magnetic stimulation. I'm just going to call it brain zapping. We zapped the brains to have a look at our brake and our accelerator. We measured muscle strength, so we could then make some inference around the effect on the muscle performance. And central to this was designing a study where athletes had stability of loading. Craig described earlier that if you do more on one day, you pay for it the next day with your tendon. You're more sore 24 hours after. So in this 3-week study design, I had to ensure that the athletes had loaded the same way the day before and measured their next day pain for 3 weeks in a row. I also had to make sure they came in at the same time of day and had had the same number of coffees. And there are a number of other things that are actually really important about your brake and your accelerator, but enough about that. In coming up with the protocols and the pilot testing, I had the benefit of Jill and Perd's and their clinical experience. But in addition to that, I had to look at the effect of my testing on my outcome measures. So what I mean by that is I was very interested in their maximal isometric voluntary contraction. I was interested in their quadriceps force. But if that test changed their decline squat pain, how could I be sure it was anything to do with my intervention, my isometric or my isotonic intervention? So I had to individually look at each of the components of my testing, including my brain zapping. Does brain zapping change tendon pain? So there was an awful lot of testing that went in. There's some research in normal, healthy participants, so people without pain. The word normal's terrible, sorry. There's some research showing that a low load isometric induces a widespread analgesic response. So I looked at very low loads that you could hold for a long time, and I looked at very heavy loads. And I looked at different combinations of all of those things. And out of that pilot testing and a lot of wonderful discussion came the protocol for the first study, which was the laboratory study. So the isometric condition was 5 lots of 45 seconds, and the isotonic condition was 4 lots of 8. Now, both of them had 2 minutes rest in between, and the 2 minutes was so that we had complete muscle, substrate, and also central recovery. Because remember, my question was, what could someone do right before they played or trained? So I didn't want to fatigue them, and I'll get to that in a second. We had a script that so that we said the same thing to each participant, because when you're doing pain studies, I can really influence your pain response by what I say. So it's really critical that you have a very organised and systematic way of going about this sort of research when you're asking people about pain. And lastly, of course, blinding the assessment so that people that were recording it didn't know which condition people were in. And all of these things I think are really important when you're doing research. Okay, so was there a difference between our isometric and our isotonic condition for pain, for motor drive, or for muscle force? There was. So in the red graph, you'll see the precondition. So this is prior to applying either of our conditions. On the left, you'll see that isometrics resulted in an immediate reduction in pain. Now, this pain reduction was measured using our pain provocation test. So we use our decline squat board as a pain provocation test for the patellar tendon. This is not the position they did the exercise in. They did a leg extension on the machine. But we would do the single leg decline squat and then retest their pain. Okay, so the isometric condition immediately reduced pain and for at least 45 minutes. The isotonic condition also resulted in a significant reduction in pain to about 4.5 out of 10. And clinically, I would take that because there is very few things that I can do to change someone's tendon pain. But as you'll see, the magnitude of difference was that the isometric condition was substantially more analgesic. What did it mean for the brain? Well, the isometric condition lifted that excess inhibition. It took the brake off. So what we saw is following the isometric condition, but not the isotonic condition, we saw that their cortical inhibition was within a normal range that's published in the research. You're thinking, great, what does that mean for me? What that means for me is your athletes will be 19% stronger. That's what that means. They could produce 19% more force. Now remember the protocol. This was 5 lots of 45 seconds at 70% of their max, but they were 19% stronger following the protocol. So this is the summary then that was born out of that initial study, that it reduced tendon pain immediately, but critically only in the loaded tendon. This was not a widespread pain inhibition just associated with exercise, because if it was, we would have seen it in both conditions. There is something about isometrics that the tendon seems to love. Remember, the isotonic was very well tolerated, but the isometric resulted in more pain relief immediately. It reduces the brake, the excess muscle inhibition, and therefore you're able to produce more force. Fantastic. I can use this in season. I can use this prior to games and training, knowing that I'm not actually fatiguing my muscle tendon unit. If we then look at the evidence for isometrics in the literature, it's absolutely, the research is in its infancy, but I want to show you what's out there at the moment because I think it can really help us start to make some clinical inferences. So in studies that have looked at low load isometrics, it's been shown to be ineffective. So in the lateral elbow, there was a 10 lots of 15 seconds at a low MVC, and they found no change in grip, strength, force, and no change in pain. There was a poster presented at a tendon symposium last year, and they did a seated calf raise and had a variable response to that intervention. And I'll talk about in the next section why I think that might be the case. Some studies have combined isometrics with other things. The challenge here is really knowing what contribution the isometrics had in isolation. There's a case study and a case series that have shown in combination they were effective. And we have some research that has supported its use in the patellar tendon. And critically, what I want you to see is what's different about these studies, because I think this can really help us. It seems that longer duration is quite important and that it needs to be heavy. So I wanted to give you some clinical tips, and I'll put it up so that you can photograph it because I'm seeing everyone getting their phone out. Okay, so some clinical tips that I would share with you, not just on the back of the research, but the pilot testing that was done. It needs to be heavy for the muscle. It needs to be heavy. The low load isometrics were ineffective for tendon pain. Now, sufficient time under tension appears to be very important as well. Clinically, we have people come and see us that have completed 3 lots of 15 seconds or 3 lots of 30 seconds and not found a benefit. So the overall time under tension appears to be very important. And we need to actually expose our tendons to sufficient load. And the Achilles is a good example. If someone can do standing calf raises, standing calf hold, we get them in standing. If they can do single leg, we get them on one leg. If they need extra load, we use something like a Smith machine, and I'll talk through exactly how we do that. But getting the load right is really important. You don't need to start light and progress them. You can actually give them a challenging load because now you understand load. This is not a provocative load for tendons because it's not fast, it's not energy storage, and it's out of compression. So you can really understand now why this doesn't provoke tendon pain. Now, why would you try that? Why would you try isometrics other than the fact, I seem very friendly and trustworthy? Or not? Because they will have an immediate effect or not. So you could do a pain provocation test, try your isometrics, and know immediately whether or not this is going to be a load that you will use in clinical practice. And that's exactly what we do as clinicians. We test something, we apply some sort of treatment, and then we retest. And this is no different. It's one of the few things we can do with our athletes in season. As Jill said, it's not expensive. I've got that as a positive, but maybe as Jill said, we need to make exercise sexier and more expensive. But at the moment, that's hopefully a positive. And it's great for self-efficacy. People can go away and do something that reduces their own pain without being reliant on, medications and so forth. So how do we use it clinically? This is a load response graph, and I'm very thankful to Mick Girdwood because I'm hopeless with animations, so he's sorted this out for me. Okay, if you're a couch potato, that's no good. You're underloaded. If you are overloaded, you're also in trouble. You might have pain, you may not be able to, compete. You don't want to be at either end of that spectrum. If you're doing something slow, even if it's heavy, that's not hard for a tendon, is it? So you're fine. So if you're doing weight training and that's all you're doing and it's slow, you're fine. If you're running, but that's within your capacity, that's within your ability in terms of your tendon and your muscle and your kinetic chain, then again, you're fine. What about if we get this person to do too much? They increase their running volume for that week, they run hills, they change something about their load, which provokes pain. This is where we would apply isometrics. And we would do this to reduce their pain, but you can't stop there. All we've done is change their pain. We haven't addressed whatever underlying deficits they might have had in their muscle and their kinetic chain, and of course their brain. So what we need to do is apply strength training, but you also can't stop there. You need to restore that energy storage capacity so that they can tolerate more. You want them down in that Goldilocks zone, as Perd's talked about. So it's very important clinically that you don't stop at isometrics or even isotonics. You have to restore that energy storage up to their required function. And Jill will talk about that really well in her presentation this afternoon. No pressure, you'll talk about it well. Okay, so if I was going to be very pragmatic, my question would be, did isometrics reduce your pain? Yes? Great. Good starting point. Go away and do that. Give them cross-education, give them the load for the other side, give them the rest of the kinetic chain. But as an analgesic tool for that tendon, fantastic. You've got a start point. What about if there was no change? The first thing I would say is if you think clinically that it is a tendon, I would recheck your load and your time under tension. Jill and I have our Desperate and Dateless clinic together, and commonly people are given far too little load. And what I mean by that is it's far too light. So we will see elite football athletes that have been given body weight calf hold. It's not enough load for them to get analgesia. What happens? They don't get pain relief, so they don't do their exercises. You actually lose adherence. In the clinical examples that I'll give you where we would still use isometrics, even if it doesn't reduce their tendon pain immediately, but because it's a way of giving some load stimulus still. And an example of this is a peritendinitis. So if you have a friction load, say the Achilles tendon, and you have an irritation of the sheath or the peritendon outside of the Achilles, the loads you want to take off are movement. So you can't give that person calf raises. So even though the isometric doesn't seem to help these people in terms of reducing their pain immediately, it's a safe load to apply. So that's where we've used it. The superficial bursa on the calcaneus, that's another clinical example where we've used isometrics to maintain some calf and tendon loading, but it doesn't help their pain immediately. But it has to be better than complete rest, and it doesn't provoke them. What about no, it was a complete disaster, my pain's worse, I'm never coming back? the first thing we double check is diagnosis. So an example might be if you have someone with a very irritated patellofemoral joint and you put them on the leg extension machine with a very heavy weight, this can be very provocative. So the first thing we would do is recheck our clinical assessment of that person. Another example is the insertion of the Achilles. If you miss posterior ankle impingement and you have someone with posterior ankle impingement in full plantar flexion, that will provoke their pain. So if someone's pain is worse with isometrics, the first thing we would do would be to look at our diagnosis. The second thing we would do would be to use another strategy. So we might try some McConnell taping or something for the knee joint to, apply a different intervention. Okay, so that's pretty much where the research finishes and the clinical presentation starts. I want to walk you through how we use this, because if we wait for all of the research for everything that we do, we'll be waiting a very long time and we won't be doing very much. So as Ellen said this morning, we need to have that combination of slow and fast thinking. So I want to give you some ideas for you to consider in your clinical practice. So if we're thinking of our lower leg tendons, we can apply anything from below body weight with a seated calf raise all the way up to a standing body weight single leg calf raise hold with external loads, such as in a Smith machine. And I want to explain to you how we would choose our starting load. If you have someone that has been immobilised because of an intervention with their tendon and they've been put in some sort of boot, then you very well may need to go below body weight. You might need to do a seated calf raise. But if that person if they can maintain even a double leg standing, that would be our preference, because you're automatically getting half body weight. So that's our preference. Clinically, if someone can do single leg calf raise holds, then they're going to need to be on one leg. If they can do multiple calf raise holds, or our elite athletes, they absolutely need external weight. So you can use your objective assessment when you're assessing their calf capacity or their calf strength endurance to inform your start load. What do we look for? We want a load that's challenging for the muscle, but not so much shaking that it's no longer isometric. That's really important. If it's too challenging and you get a lot of bounce, it's not well tolerated. We ask our patients with Achilles insertion to be up very high, so full plantar flexion so that they're out of compression. We do the same for plantaris. For the mid-portion Achilles, because of the posterior retinaculum, we just go mid-range. And Sume's, who's the Australian ballet physio, taught me this, and it's fantastic. If you line up the middle of your ankle joint and the middle of your second toe joint and draw a line in between, if you maintain this alignment when you're teaching people calf technique, you can actually use a calf raise or a calf hold with good technique as your isometric for all your lower leg tendons. Because this position, you're out of compression for your tibialis posterior, you're out of compression for your peroneals. So not only do you want to retrain this in clinical practice, you can use that position and just modify the range that you're in for your lower limb tendons. For the patellar tendon, we have research for both the leg extension machine, and we've also just published the Spanish squat that Angel Bassis described in 2013. And the reason why we did this study is everyone said, well, that's fine, but when I travel, my athletes don't have access to a leg extension machine. What could we do when we're traveling or we're on the road? You'll note, or please I hope that you'll note, you don't do isometrics on the decline board. The decline board is a pain provocation test. We would do isometrics, either our preference for patellar tendon would be leg extension. The Spanish squat is hard, so it's still very good, even though it's double leg. Okay. For Gluteus Medius, we do a hip hitch, and I'll encourage you to read Charlotte Gandinen's wonderful work. You need to be well supported with straight legs. That's isometric load for your stance leg. Again, see what the person can do. It doesn't have to be a 5 by 45 second recipe. If they're losing technique at 40 seconds, that's their protocol. Jill, our wonderful model, highlights here how important kinetic chain is. It's really well understood when you consider the glute med, because if you have someone that has poor eccentric quadriceps control, as they lower down a step, if their quadriceps are poor, they get into a lot of compression of their tendon and their bursa against the greater trochanter, okay, especially our postmenopausal women that have the hip angulation. So if you give these women quadriceps and calf work, not only can they lower down, they can actually take their weight with their calf as they go up and down stairs. This is one tendon that we would give double leg work, because single leg work they can't control and they get a lot of pain. The hamstring I'm going to skip over because Purds is going to do such a stellar job that I'm not going to do it any justice here, and he's going to describe it really nicely. So the clinical take-home messages, I found this board, How to Survive a Boring Meeting. This is on the wall at the Novotel where we're staying. And you'll note number 2, practice your isometrics. Go the Swiss, they're all over it. But if I could modify their board, this is what I'd say. You need sufficient load. I'm not sure under the table in the boardroom you're going to get enough load. Load's really important. So heavy is what your patient can do well, but it can't be too easy, and people are really good at giving you that feedback. If they could hold that position for over a minute, you need to add load. It's really important. Sufficient time. We're using 5 by 45 seconds. Please take this as a guide, not a recipe. If you're using isometrics for the purpose of pain relief, I would encourage you to be guided by this. There are people out there saying, oh, but I do 5-second holds. I can tell you with utter confidence in an 18-month pilot test that is not effective for tendon pain. So make sure you've got enough time. And, it wouldn't be isometric research if we didn't say more research is needed. And that is true. So again, thank you so much. I'm thrilled to have been here. Thank you.